Dr. John Kim, the functional pharmacist. You're back. We got you back after long lost.
I know. I think this is my fourth time to be in your show. I think I might be the most invited guest ever.
You are.
So thank you. Thank you so much for doing this again.
That's because you're one of my besties. So we got to bring you on. You and I have lots of great conversations. If the world only knew all the cool stuff we talked about and all the fun memes we share.
Oh God. If anyone out there, if you could see the type of memes and the jokes and the articles that Dr. Tina and I end up having to share each other every single day, mind you, every single day, every single hour, you'll have a thrill.
So today you did a reel a few months ago, and I wanted to bring you on because you were talking about how the price structure of the pharmaceutical drugs are done. And the reel was great, but I was super confused. And I thought we could try to break this down over the next 30, 40 minutes of how does this work? People don't understand when if they have insurance, they go and pay, they have a copay of some sort on their drugs or they get it for free. I understand it a little bit only in that behind the scenes as a physician who can purchase drugs, I see their price at wholesale and it's a whole lot different than what I see coming across the counter at the pharmacy. So you were going to talk today about all of this.
Yeah, I mean, it is a complex discussion to make. And, surprisingly enough, even pharmacists don't even understand it because pharmacists in general, they end up having to be working for a chain or independent pharmacy or hospital. And they're so busy dispensing rather than looking at the actual cost. And even then, they don't even know what's being covered, what is not. And then when you factor in the patient's deductible, that's an annual thing that they have to pay. So if anyone not familiar with what deductible is, so let's just you get into a car accident, you have to fix your car. The first set of amount that you have to pay could be 500 up to 1,000. You have to pay that until your initial benefit kicks in. That's exactly what happens with your insurance company as well. So let's just say you go to hospital and then you get injured, the procedure, you may have to end up having to shell out $5,000 to almost $10,000 into deductible until your initial benefit kicks in. And that goes into pharmacy at the same time. So it's really complex in that sense of that. And at the same time, there's a lot of things in terms of there's so many insurance companies and as well as the different middlemen out there. And the particular middleman we'll talk about today is called the pharmacy benefit managers. And I'm not going to point anyone out because that's not what I'm here for. I'm just trying to explain what the market looks like and explain about it. And I'm not trying to vilify or anything else. It's just the overall complexity of the system is too big to unravel that even just the pricing structure we're going to talk about in itself can be really daunting as well. So that's the reason why even the professionals are having trouble. And I mentioned to Dr. Tina about this before the pandemic started. I usually regularly go down to Washington, D.C. and talk with lawmakers, not for anything else, but to protect patients' access to compound prescriptions, as well as particular drug coverages and what that means for the community. And lawmakers are really want to protect that because obviously they want to protect the ends of their constituents. But the problem is when you go down to Washington, D.C. and you want to talk with the lawmakers, you don't talk with the lawmakers, you talk with the interns, right? And so there's a lot of brokenness in that because you may end up having to talk to an intern. They don't fully understand or grasp the entire policy, and they end up having to maybe shove it at the side, or they may end up having to not translate that particular message to the lawmakers correctly. And so there's a lot of brokenness as well. On top of that, there's a lot of lobby groups, right? You think that you're selecting your lawmakers, many cases not the case, is the lobby groups who actually fund a lot of these things to get the lawmakers elected to protect their end as well, because they're in the business to protect their overall profit. So that becomes a lot more difficult part that I end up having to, at least my colleagues and I end up having to fight the uphill, and it's exhausting. So I haven't been to Washington, D.C. over 2 years at this point in time. At one point, I was invited to the White House to talk about drug pricing policies. And even then, just talking with the White House officials, they don't even understand it quite readily, right? So if lawmakers and policymakers, even healthcare professionals are not able to understand the drug pricing model, how would a layperson end up having to, as a consumer, going to a pharmacy, buying different drugs, and all of a sudden, there's such a wide price range you see. So a good example is, let's just say you go to a GoodRx website. That's pretty popular these days, right? You go to a doctor's office and they have different discount cards you could get for free. And you know what? And you go online and to do a price comparison, it could range between a simple drug like a finasteride, for instance, that's the prostate medication, could range between like $15 all the way up to 75. But why is there such a price difference there? When I could, for me as a pharmacist, could end up having to purchase drug at a low cost of maybe $1 or less, right? So why such a price spread? And then even there is a price spread, who's reimbursing it? At the same time, who's keeping or at least pocketing all the difference? That's the one part that we never know about. And that's the reason why your drug price is always high when you end up having to go through certain different parties or certain different pharmacies. As a consumer, I want everybody to do their due diligence. In many cases, it's sometimes cheaper to go to an independent pharmacy, a mom and pop shop. I know that's so hard to find these days in a rural area, for instance, but it's the best idea to work with the pharmacist one-on-one and try to find a cheaper alternative, or maybe find a better negotiated rate for yourself, just working with the pharmacist.
Okay, so who does pocket that amount in the middle?
Well,
how does that get sorted out?
Well, even before we could talk about that, we have to talk about why there's such a widespread and who controls that and who determines all those things as well. So we know that there's an insurance company that end up having to cover our health benefit. But back in the 1960s, the amount of drugs that were actually being formulated and being made by the manufacturer and having it available for the pharmacies was getting bigger and bigger. And at that point in time, nothing was electronic, right? Everything was paperwork. And so, back in the day in a pharmacy, anytime you dispense one particular drug, the pharmacist would end up having to, fill up a triplicate form. It's carbon copy. I don't know if you guys remember those, but
yes,
showing our age.
Yes.
Yeah. So that is basically what you have to fill out and then send to an insurance company. But remember, it was so small in terms of formulation of drugs that you had to deal with. Formulation meaning what's covered through the insurance company. But now when you talk about thousands of drugs at the same time, thousands and millions of pharmacies all around, it's so hard to keep track of that. So what happened was that there was a middleman to handle all those paperwork. And that's a particular thing called pharmacy benefit managers, or PBM. And PBM was there to take care of the operation aspect in terms of drug reimbursement, to check for drug coverages, meaning that what drugs should be covered and what should not be, right? When there's a cheaper alternative out there, that should be the first thing that should be covered instead of having an expensive one, unless you end up having to have side effects, or you end up having to be the fact that, hey, you tried the first one, not working, fine, let's go to the other one. And then there are certain things like something called a drug utilization review, where there's certain things make for a particular expensive specialty drugs, like a injectable biologics like Humira or Cosentyx, for instance, that's for rheumatoid arthritis. There has to be a guideline in terms of you have to hit these criteria to get those drugs covered. Because if you don't, what happens? You're going to be spending $6,000 to almost $10,000 on a drug that you may not be even needing until you go through the entire criteria. So in terms of what the PBM is doing is controlling costs. That's what they're doing. That is their primary role. The issue is that there are only a handful of these PBMs end up having to control the entire market. They control 80% of the market, and they manage 180 million Americans.
Who do these guys work for?
They end up having to work for insurance companies. So, so for instance, Horizon Blue Cross Blue Shield, Kaiser Permanente is the big one in California right now, right?
Okay, so these pharmacy benefit managers work for the for the insurance company, the health insurance company, and they help manage the cost of the drugs that are being prescribed by the doctor.
Correct. Or coverage of, and then the reimbursement, what tier range of the drug will be covered, and that could determine your copay as well. Sometimes a particular cheaper generic may not be a accepted tier, meaning that depending on where the range of ABC in a tier service, it could be more expensive or cheaper, or may end up having to require a pre-approval. And I bet you that a lot of these listeners out there, you may end up having to get a topical cream, for instance, and go to a pharmacy, and the pharmacist is like, well, it's not covered right now because it requires a pre-approval from the insurance company. So those are things that is important, right? You don't want drugs to be just handed out for no reason when they could end up having to utilize some cheaper alternative, like a over-the-counter allergy medicine, for instance, instead of going through a whole slew of other things that could be prescribed. So there's a role for PBMs playing, and as well as there are things that they end up having to do well on.
Okay. Let me ask you this. So I never took health insurance in my practice, but I knew how it worked. I studied it really well because I thought it was such bullshit that I wanted to make sure that I understood it. And I spent hours and hours and hours studying it, to be honest with you. I kind of got geeked out on it for a hot minute. What happens so I'll give you an example. I'll give you two examples. One is the patient doctor insurance relationship. And then the other would be like a third variable, which would be an imaging center, let's say. So we, as the doctor, say we were in network, we would charge the insurance company a certain amount, and knowing that we would get paid pennies on the dollar. So the doctor would charge an exorbitant amount, much higher than you would think. And it looks kind of crazy on the bill when the patient gets it, when they get their explanation of benefits. But the insurance company would deny most of that and only pay them on a pre-agreed amount. So say $100 for a 30-minute visit, the doctor might get 30. Now, these are not accurate numbers. I'm just giving examples. If you're out of network, say the doctor's out of network, then that amount would be roughly the same, probably not as much because it's not negotiated as if you were in-network doctor, but the patient would have to pay a higher percentage of the overall bill. So they might get some coverage from their insurance, but they would pay a higher percentage. Now, what I've seen with imaging centers and labs is that there's the doctor price. So say I wanted to get the lab kit and have it in my office, I could pay one price for that. I can upcharge that to the patient, a slight amount, and that would not be me upcharging the lab, but it would be a handling fee, a quote unquote handling fee. So that there would be a patient price, which would be in the middle, or if the patient were to pay the lab directly, it would be at a much higher rate. And then insurance is in there as well. So the lab will charge the insurance company a crazy amount of money. So say I can get a panel for a patient through a lab co-op for $250. Often that same panel would cost the patient $2,500 if they build their insurance. And sometimes the insurance company won't cover it. So now they're stuck with a $2,500 bill when they could have just paid me in the clinic, or actually paid the lab co-op $250, completely out of my hands. So I only share this because I want the audience to understand how many tiers there are and how much nonsense can be involved here with this system. How does it work with the pharmaceutical industry?
That's actually pretty similar to that as well. So just to give you an example, I mean, it would be easy for me to actually have a board and a pen or marker just to write everything out. But being that you're just listening to my voice, I'll make it simple. There is a particular thing called average wholesale pricing. And that's average wholesale pricing is called AWP. And that AWP is basically just what it is. It's an average wholesale pricing that's basically preset by the manufacturers. Because why? Because if you actually have, 4 different wholesalers having 4 different pricing, it would be very, very difficult for the insurance companies to reimburse. So you need to have an average pricing in a national level, right? Depending on the particular drug. And drugs, when you dispense it, and when you bill through the insurance company, it's not built based on the name, right? There's a particular, either a diagnosis code that doctors end up having to use, but in pharmacies, it's built based on National Drug Code, NDC. Okay, and that particular NDC numbers had the AWP pricing on that.
Okay.
So now, hopefully that doesn't lose anybody yet.
Let's give an example. Just give me some numbers here. Let's just say we're talking about fluconazole, an antifungal.
Fluconazole, for instance, is very cheap at this point. I could buy that for $1.50, right? For one time, a pill.
Okay,
right?
And then is that the AWP or the NDC?
That is my overall cost by the pharmacy.
Okay.
Right. So the AWP could be ranging around $75.
A pill.
A pill.
Wow.
Why such a big spread?
Yes, why?
That's how it's set up as. Right. That's who determines that? That's the manufacturer.
Wow.
Manufacturer says that. So now you think about that. $1.50 $7.50, right? And what happens is the PBMs may end up having to dispense the pharmacy $4 to cover that entire thing. So $1.50 to cover my costs, $3 something to cover my expenses, and then profit, etc. Right? The entire difference there, what happens to that difference? That is the one that's actually mysterious. They are stating that that could be one of the things that is a pre-negotiated rate, and this is what we end up having to do to save the end user, the patient's pocket, but that spread being built to the employer up top, right? So whatever difference is, we'll say, hey, Joe Smith got this particular drug and we cover $4, but they don't say that. They end up say, Joe Smith got this particular drug, we cover 75, we charge the employer, and that particular spread that goes on the PBM's pocket.
So this is where I get confused. So you say employer, do you mean the insurance company or?
Employer. So United States is a unique case, right? Other countries, health insurance is administered by the federal government or the government in itself.
Okay.
United States, a different model where the insurance is being administered by the employer, the companies. So let's just say you're working for JP Morgan, for instance, right? A big bank. The bank or your company you're working for administer that particular health insurance by contracting with the insurance company. That's what the health human services come in and et cetera, right? So that's always the complexity of it. But in terms of what the PBMs end up having to negotiate the pricing on, and then the pricing spread difference, that's where the PBMs end up having to pocket, and then they end up having to overcharge the employers. And so the employers, being that they don't really look at the pricing, are they going to look at every line by line item in terms of what's being administered to their employees? Absolutely not.
I had no idea that this was a piece of it. So if I worked for JP Morgan and I was on a very expensive drug because I was super sick with something, or I was super unhealthy or whatever, my employer would be paying the difference. I thought they just covered the cost of my health insurance.
Not always. And this is one of the things that even drug policymakers as well as the government officials now are seeing, and they're going after the PBMs because the entire market is not regulated at all. Right. And that's the reason why some of these PBMs made $15 to $20 billion last year.
So the PBM is a employee of the insurance company. They work for the insurance company.
Or so to interrupt, sometimes they're vertically integrated as well. So meaning that the insurance company owns the PBM as well, and they end up having to control the entire market.
I see.
And this entire thing is so hard to unravel. That's the reason why, unless you understand the entirety of this market and how this actually works, you're not going to get it. And then you're like, how's that even legal? Because not regulated, right? And I'm all for it. And listeners out there, I'm 100% libertarian. I want free market approach, sound money, fiscally conservative guy here. But thing is, this is the shit that happens in a free market where big companies like these end up having to abuse the entire system, rip the money from the public, and this is the bullshit that you're dealing with.
So the fluconazole costs the pharmacist $1, let's say, and the insurance or the PBM is going to reimburse the pharmacy, your pharmacy, $4 a pill. So you get a $3 profit, and that covers your costs and hopefully some profit. Right. And the employer pays $75 a pill.
Just letting you know, everyone listening out there, this is just a theoretical number. This is not something that is. This, just to give you an example.
Just an example. Just say the employer pays $75 a pill, then the PBM pockets the difference, the $71.
Correct. And so, well, again, this is negotiated, and then that
like a stockbroker.
Exactly.
Kind of.
Right. And there's certain administration fees that end up having to take from the pharmacy as well. So each claim that the pharmacy transmit to the PBMs, they pocket between 10 cents a claim to up to 40 cents a claim. But think about how many prescriptions go through on each daily basis.
So the pharmacist isn't getting rich.
That's not the case at all, right? Even then, so everybody thinks that the big pharma end up having to control these things. Not at all. Because even then, let's just say there's a new particular drug that comes out from the big pharma, and that's a complete effing joke to begin with these days, because there's no other drugs in the pipeline, right? They only just copy shit, end up having to do other things, and now they're going to the entire gene therapy now, quote unquote. So big pharmas, for instance, let's just say they get a new particular drug out into the market. Let's just call it ABC drug, right? And that particular ABC drug, in order for that particular drug to be covered by the insurance company, the PBMs have to review the drug, review the clinical data, and compare in terms of where that particular drug fits into their client's list of ailments they might be dealing with. And then they also have to set up the formulation, meaning that why that particular drug is covered and how much. And in order for that particular drug to be within the formulation, there's a particular rebate that has to be set between the big pharma and the PBMs. And that's all based on how much they're willing to pay for that particular drug to be on formula. So think about that. That's almost
it's like price splitting.
Price splitting. That's what it comes out to, right?
Which is illegal in medicine.
Yes, it
like
is.
If I were to send a patient to you to get a drug compounded, you're not allowed to give me a kickback for the referral. It doesn't work like so people understand. So the listeners understand. If I have a relationship with a local imaging center in town and I send a patient to that imaging center, I don't get a referral kickback like most entrepreneurial businesses work. It's not allowed in medicine. It's called price splitting.
Price splitting. I think there was
fee splitting.
Anti-kickback laws. Stark law is another word, right? That's what it comes out to. And this happens all the time. And so I don't know if any listeners out there remember back in, I think it's 2017, the entirety complaint was, excuse me, it was 2010, I think was, nearly 10, 11 years ago. There was a entire national complaint about why EpiPen pricing was so high, right? It was down at $70 for a pen, and now it's up to $200. Like, why is that price keep on going up? It's not like the cost of manufacturing had gone up, maybe to a point that it goes up from 70 to 200. I don't think so. If a milk price goes up that high, you think the entire people out there in the population wouldn't give a shit about it? Of course, they're going to go in a berserk, but never happens, right? So this entirety of that. So the CEO of the pharmaceutical, again, I'm not going to mention which pharmaceutical company. Listeners out there, you could go on Google and then Google it if you want to. But the CEO of EpiPen was in stance in Congress and was asked, like, why there's such a price issue? And then her point was, well, that's because of the PBM, because she has to give those rebates to the PBMs to get the particular drug on formulary. Right. And then that's the reason why, in order to build up that enough buffer of a room for the profit to be generated for the big pharma, what do they have to do? They have to also increase the price on the drug. Right. So who's getting screwed is a consumer at the end. And that's the biggest issue there. And then another thing that we have not talked about is there's other clawbacks as well. So there's entirety of the clawback that's been generated, is thing called a DIR. It's an indirect rebate. It goes into a DIR, just call it DIR. And what happens is that there is a clawback, meaning the insurance company or the PBM is going to be taking back the money after 6 months to a year after the drug's been dispensed to the patient. So let's just say patient comes in, they pay $35 for a copay, even though drug may end up having to cost $2 or so, right? So that price spread in terms of what they pay to the pharmacy. What the insurance company or the PBMs will end up having to do is that, hey, we checked all the payments that we had given you for the entire year. I think we overpaid you. So we're going to call back $28 after 6 months to a year after we dispense the particular medication.
They call it back from the PBM or from the pharmacist?
From the pharmacist.
Oh, you're kidding me.
So this happens all the time as well. And so this actually happens within the Medicare Part D coverage, Medicare. And that's all because of Obamacare back in 2008, when it was actually administered, actually was passed. There was a particular sentence within the bill talking about improving the patient's overall outcomes and quality assurance measures as well. So that quality assurance measure should be paid by the employer who's administering the plan. Unfortunately, they didn't really set who actually going to be paying it. So what the PBMs are doing is they're clawing back all this money from the pharmacies to collect those fees they need to administer this quality assurance program. And that overall is based on diabetes medication, high blood pressure medication, and cholesterol medication. Those are three classes of drugs that the PBMs look for. And this is set by the Center for Medicare Services, CMS.
And those are the most prescribed drugs in America.
Most prescribed drugs. And so depending on how well the patients are taking also would end up having to affect the overall quality assurance, or we call it the star rating of a pharmacy, and as well as a prescriber. So let's just say Mr. Smith gets a prescription for Lipitor or atorvastatin, for instance. He gets a 90-day supply, but he's late 14 days to refill his prescription. The pharmacy and the prescriber gets a bad rating, basically, that we haven't done the due diligence in terms of reaching out to the patient and then taking care of their overall outcome. And we get penalized for doing that.
Oh, okay. This explains why I would get faxes from the pharmacy saying, have you reminded your patient to, there was all these automated faxes that
How screwed up is that?
That's horrific. I want to add something here just because it's a little off topic, but it's not. I have had to correct so many people, including my husband, about this. And so I want to just say this while we're on the topic. Doctors don't make money by prescribing drugs. There is no kickback from the pharmaceutical industry that we get for prescribing drugs. We don't get paid for prescribing opioids. We don't get paid for prescribing testosterone. The only people that pay us are our patients for the patient visit. We are not allowed to actually, there's no pharmaceutical rep coming in saying, hey, prescribe this more and we'll give you money. Now, there used to be incentivization, but now you have to claim all that as a physician. So I've never had a pharmacy rep in my clinic because I wasn't a big prescriber, but I did prescribe my fair share of pharmaceuticals when needed. But that is something that I think is a misnomer. A lot of the world thinks you pharmacists are getting rich from this, and they think us doctors are getting rich from this. And that's what I want to clear up right now, because we just stated you're not getting rich. And us as prescribers, as physicians, just seeing patients, we're not getting rich off of this, because you guys are doctors too. I'm clarifying, but it's assumed that we are just sitting around writing scripts all day to get rich. That's not how this system works. That's a whole topic for another day, how health insurance works. But just clarifying, your doctor's not getting rich. Your pharmacist isn't getting rich from any of this. Somebody else is. It sounds like these pharmacy manager people are.
Yeah.
These PBM people.
Yeah. So, I talked about before. They're publicly traded company as well, right? So that's another problem.
The PBM?
Yeah, they are.
Wow.
And then one of the PBMs is owned by one of the chain pharmacies as well.
Wow.
And then they also have done many vertical integration, meaning that the insurance company also owns a PBM. Also, another thing that this is the biggest issue that we are seeing at this point in time, because they have so much capital, now they're buying hospitals and healthcare clinics as well. And they're controlling the entirety of the healthcare model at this point. So why they're doing this, I think why is that soon enough, it's going to be a one-payer single model. That's what it comes out to.
We're the customer, right?
Yeah, we're the customer.
Eat the shitty food made by big food, take the crappy pills. Well, my solution always with patients when they were complaining about their drug issues was, why don't you get off the drug? Why don't we do everything in our power to get you off the drug, so then it's not a big, huge expense? I understand that sometimes we need medications. And I am the first to say, if there's a zombie apocalypse, I will be sacrificing squirrels and sucking their thyroid gland out so I can get my thyroid. I thought about this, John.
Not a pig. I think pigs are better.
I don't have a pig, but I have maybe a deer. I've got a deer. Anyway, I know the vegans are going to hate. The vegans are going to hate.
Guys, these are the type of jokes that Dr. Tina and I do every single day. You got to see our DMs and our chats all the time.
We think about these things, right? We're planning. We're ready. But for real, I used to be somebody who was, and I won't make it a long story. I was on a lot of pharmaceuticals at one point in my young life. And I remember being afraid to travel, being afraid to leave the country, being afraid to do anything fun that a young person would normally do because I was afraid I would run out of my medication or I wouldn't have enough or something would go wrong. And I was a complete slave to my meds. And so I know exactly what that feels like. And I can't imagine as you're older and you're dealing with chronic degenerative illnesses that are predominantly lifestyle. My audience has heard me say that before. I mean, most of these are mitigated and caused by lifestyle and reversed only by lifestyle. But unfortunately, we live in a model where people are on, I mean, God, what's the age group? Like, I know over 50-year-olds are on 5 different medications on average, most 50-year-olds, but like
Polypharmacy.
even young people, the stats I've seen on young people are greatly disturbing. So, again, another like high five to what you and I preach, which is just good, clean living.
Yeah. Well, I'm not a big fan of medications to begin with because there's a lot of potential permanent side effects and also biochemical changes that could go on and etc. That, knowing this on my end and having to own a pharmacy and then seeing how many patients are actually taking these drugs, you start to cringe. You know what I cringe about? Dispensing birth control pills. I do.
Yeah.
Yeah. I'm all about empowering women and such, but the amount of female patients are taking birth control pills, even early as 11, 12 years old, just to control the menstruation issues is mind-boggling. And then having to deal with all the other consequences later on because they took it for so long, and then they're dealing with drug-induced nutritional depletion issues. And on top of that, the gut function is all screwed up and such. Best thing to control your overall healthcare cost is to take care of yourself. The doctor of the future is you. You need to be your own doctor, right? This is what Dr. Tina and I end up having to preach all the time. I don't care if you have to take vitamins and such, but the thing is, you need to take care of yourself by sleeping well, eating well, pooping well, and I think I said eating well, but exercising well, everything, right? And de-stressing well. Those are the things that really build dividends for your health instead of trying to rely on a broken healthcare system model, sick care model, that we see, and we're completely dependent on it, right? Anytime for people out there, even thinking that they're going to keep their job because of a particular insurance coverage for their family, if that particular job is making you sick and not performing well as a parent, for instance, does that health insurance really suit the need for you? You might as well give it up and then find something else. But this is the things that we end up having to see. And so I really encourage people to listen to this, think about it for a second, what you're spending money on in terms of your overall health. It could be the drugs, could be the vitamins, and really think about what's going to really build up the overall health dividends for the long term to live a happy, healthy life.
Deadlifts and squats.
And eating meat. We got to eat meat. Okay.
Oh, goodness. Yes. The vegans are so mad at me this week. Yes. So for everyone listening, Instagram literally took my voice away off my reel that was doing well because I said eat meat and lift weights, but anyway, John, I am so appreciative of you for explaining this. I know it's complicated. I know there's probably more to it, but for fear of overwhelm, I think we should probably wrap it up here because
absolutely.
I think that was a really great explanation. I hope the audience will go back and listen to this again so they understand. Get out of the system, you guys. Do everything you can to get out of the system. What Dr. John just said, getting yourself autonomous truly means autonomy and health, and drinking the soda and eating the junk food and eating the fast food that Big Brother is providing you to wrap you up into this system forever as a customer is where it starts. So you can't be a libertarian and a medical health freedom activist and be sucking down Big Brother's food, right?
Absolutely.
Yeah. Awesome. Well, John, where can they find you?
On Instagram, Dr. John PharmD. Another thing, you could visit my website, drkimwellness.com.
Awesome. Is there any ending thoughts you'd like to leave the audience with?
Yes. Just as I preached before, the doctor of the future is you. You need to be your own doctor.
I love it. All right. Thanks for coming on, John. We'll talk to you soon.
Dr. Tina, thank you so much.